Good evening, everyone. My name is Lena Abdelaziz, and I work with the Virginia Department of Health. I'm their medical search coordinator for COVID-19. So we'll be going through, I'll give you a little bit of overview, and then we turn it to Jasmine, and then Megan, and then our two MRC volunteers at the end. Next. So what do you expect to learn from today's session? First, we're going to give it a little bit of overview of the strategic national stockpile. Then we're going to talk a little bit about the state and local dispensing systems here in Virginia. Each state has its own local and state dispensing systems. The third thing that we're going to cover today is points of dispensing, operating structures. And then we're going to review the CDC COVID-19 vaccine distribution. And at the end, we're going to talk a little bit about the roles of volunteers during MCM, and that will be delivered by our two volunteers. Next. All right, so I'm going to give you a little bit of overview about the strategic national stockpile. Next. So what's the objective of the session that I'm going to cover? First, strategic national stockpile, and then I'm going to talk about the state and local dispensing systems. Next. So what is the strategic national stockpile? We call it SNS. So the strategic national stockpile is a nationwide supply of life-saving pharmaceuticals and medical supplies, and actually managed by the Federal Department of Health and Human Services at top. And it's under an office called the Office of Secretary Preparedness and Response. It used to be under CDC, but now they moved it about 2 years ago to ASPR, which is the Office of Assistant Preparedness and Response. The SNS is actually caches that is strategically located in secured warehouses across the United States. Next. So what exactly inside the SNS? When you see the picture here, this is an actual warehouse where the SNS is one of the SNS warehouses. So it has a lot of personal protective equipment. It has ventilator, airways management. It has actual pharmaceuticals, and it has some testing supplies and more stuff that I just mentioned, the big stuff that they have it there. Next. So how is the SNS program works? What exactly the scenarios that the SNS can be deployed to? So normally a governor of that state requests the deployment of SNS. So let's say there is a disaster, there is an emergency, there is an outbreak, whatever the state needed, they don't have it at that moment. So then they can go ahead and request that through HHS, through ASPR, which is the System for Preparedness and Response. And then through that formal request, the deployment process will start. So first, they sent what is called the 12-hour pushback. They call it 12-hour pushback because there is a guarantee that it comes within 12 hours or less. Actually, these days, the pushback can come between 6 and 8 hours. The 12-hour, that was years ago, but right now they work the system. They can deliver those pushback between 6 and 8 hours. The pushback, that's the stuff that it has in the pushback. That's the stuff that I just showed to you guys in the slide, the previous slide. This is how the pushback look like in the picture in front of you. So this is how it's delivered to one of the warehouses. Each state has strategically warehouses around the state to get the supplies. So for example, Virginia has 3 warehouses put strategically around the state of Virginia. So once, if we request a strategic national stockpile, it can come through by airplane or by buses or by trucks. So it depends where it's coming from. The other part of the strategic national stockpile is what we call it the managed inventory. And that normally we request the managed inventory if we know exactly what the situation is. Like for example, COVID-19 vaccine, it will come through what we call it managed inventory. We know exactly what the problem is. We have COVID-19, we need the vaccine. That's how the mechanism that is going to come through, because we don't need the rest of the stuff. We just need that vaccine. So that's what we call it the managed inventory. Hit next. So this is a picture. This is an actual picture of strategic national stockpile that has been delivered in some of the warehouses throughout the state. You can see the National Guard, sometimes the military will come and help us unpack, and then we can pack it again and send it to localities to be sent. This is an airplane. Sometimes it comes by airplane. Sometimes, as I said, it comes by trucks. It depends where it's coming from. Next. So I want to talk a little bit. First, I want to say the strategic national stockpile. Some of the examples that have been deployed. It was deployed for 9/11 to New York, and actually that was the only airplane in the sky during that time that was delivered. So that's something I found unique, that they allowed the airplane to fly from where it is to be to New York. And then for anthrax, 2001, H1N1, 2009, all the hurricanes that throughout last years, from Hurricane Katrina to all the big hurricanes, the wildfires, all the different disasters that need an assistance, we send the Strategic National Stockpile, or HHS send the Strategic National Stockpile to the requested states. So here I want to show you a little bit about the role of the states and the localities. So at the state level, Virginia Department of Health, what we do, we receive the stockpile, we unpack the stockpile because it comes as a bulk. We unpack it and then we store it if it needs to be stored. Sometimes we send it right away to the localities if the need is right away, immediate. And we also distribute, as I said, secure and distribute. What we mean by secure, we work with the state police, the Virginia State Police. They work with us, and we also work with the different airport police to secure and kind of transit the materials to different localities. And other state governments, for example, the state capital, they receive their own pushback. We send the different departments throughout the state different materials or whatever they needed to vaccine or secure their people. Another role, there's so many other roles, planning and finding the warehouse, I mean, getting the route. There's so many planning involved that we do on a daily basis to be ready for such scenarios or such when we request the SNS. I thought I will mention another role that we do, which is the public information and communication. Definitely when there's something like that coming up, the state will work with different outlet of media to kind of put the message out. There is a vaccine coming, so the public can be ready. The locality, normally they're responsible for receiving that pushback that we send it to them. They secure it also with their locality police or fire or whatever they choose to do. For each locality, they have different plans. And also their responsibility mainly to actually dispense those medication to the public. If it's vaccine or pills, they're the responsibility of locality, and that's what the role of the MRC comes in. Also, localities are responsible for the public information communication. They need to send to local media, to the newsletter, to whatever outside, so the public will know where to come in to get the vaccine or to get the pills. Next. So that we have different dispensing system. So when we say pod, we mean point of dispensing. So we have two different point of dispensing. We have what we call it a closed pod, and what we call it an open pod. The closed pod is normally we ask big departments or jails or big companies like Dominion Power or all these different big companies. They can come and get the medication from us or the vaccine from us, and they can give it to their own people. So they kind of create their own closed pod within their facility. And also fire, police, all what we call them first responder, who they need those medication and vaccines up front. We send it to them. They take care of their own people, and we're done with that population. That actually helps us a lot when it comes to the open pods, because then we can take care of those who are closed pod, and we can come back and open those big open pods for the public. So the open pod, as I said, it's point of dispensing. It's open, so it's open to the public. We normally pick a side like public schools, sports arena, gymnasium, community centers, any big, sometimes parking lots. So it depends on the locality. Each locality, they pick certain location to dispense their medication or have a plan how to dispense their medication. Jasmine will go more on the locality, what they do and how they plan it. Also, we have what we call it mass vaccination clinics. We partner with big clinics to send them the vaccines, and they can distribute to the public. Also, we have MOUs, which is signed with different pharmacies like Walgreens, Walmart, different big pharmacies that we have an agreement with them. We send them the vaccines, and they can distribute to the public for free. Next. All right, so that's all I have. I will turn it to Jasmine. Thank you, and we'll take questions at the end. Thank you.
Hi, everyone. Can you hear me?
We can hear you well, Jasmine. Go ahead.
Fantastic. So, hello, my name is Jasmine Johnson, and I am the Assistant Public Health Emergency Management Coordinator here at Alexandria Health Department. And we're going to go over a point of dispensing overview. Next slide. So the objectives that we will go over today or this evening. So to understand public health emergencies that require pod activation, and then describe types, purpose, and functions of pods. And then pod operations, which is to prepare volunteers. For us, it's definitely focused on Alexandria Health Department and our city staff to work in a non-medical or medical pod. Next slide, please. So the dispensing scenarios that most of you, anybody would face working in a pod, we begin to consider the need to dispense when two factors are involved, that people have been exposed to an infection that make them sick, and disease from that infection may be treated by antibiotics or vaccines. When we plan for dispensing operations, there are a variety of scenarios upon which we base our planning. The first is naturally occurring diseases such as H1N1, or now we're focusing on COVID. Our dispensing plans also apply very well to other public health activities such as tuberculosis testing, or anytime we need to accommodate a large numbers of clients in a short period of time. Finally, we'll be expected to run dispensing operations in response to acts of bioterrorism. Next slide. So here are some public health emergencies that may require a pod. These are what CDC defines as Category A disease agents. These are diseases which pose the greatest threat as agents of bioterrorism. These are high priority agents, pose the highest risk to the public and national security because they can easily spread or transmit it from person to person. They result in high death rates and have potential for major public health impact. They might cause public panic and social disruption, and they require special attention for public health preparedness. Some of these diseases may be mitigated by dispensing operations, and others do not have effective prophylaxis or treatment. For our training here today, we will be focusing on dispensing in response to either vaccine or bioterrorism event. So pretty much any a pod can focus on both. But considering our time, we're going to definitely focus on vaccine dispensing. Next slide, please.
Hi, Jasmine. Can you just speak a little bit more into the microphone? We're having a little trouble hearing you.
I apologize. Is this better?
Yes, slightly.
Is this better?
Yes. Thank you.
Okay, no problem. I apologize. All right, so responding to a public health emergency, we are going to talk about dispensing. This is CDC's public health preparedness capabilities, which is the medical countermeasures dispensing. I will allow you for a moment to go ahead and read this definition before I continue, which is on the slide. All right, so basically dispensing is getting medication to people outside of the established healthcare system in response to a public health emergency. In addition to medical countermeasures being a capability of the public health preparedness capabilities, it is also one of the capabilities and it is a target in the national preparedness goal. And air slides anthrax is one of the 15 planning scenarios in this national planning. Next slide. So here is the ICS structure of what our health department is actually currently using for our pod sites. It may look different from your health department structure, But we have a few additional roles, such as a biosafety officer in our point of dispensing site. And we have different roles for inside flow, outside flow. We also have support service, which is usually known as access and functional needs. So we've changed a few names around, but they still serve the same purpose. Next slide. Okay. What is a the public health answer to respond to a national occurring disease outbreak or an act of bioterrorism is pods. And Lean mentioned it in the slide deck earlier in her presentation that a pod is short for point of dispensing. It is a site where medications or vaccines intended to prevent disease may be given quickly to a large number of people. Pods can be located in any type of big or small, and every jurisdiction does it a little differently. In Alexandria, our primary pod locations for a large-scale dispensing are either our public schools or our recreation centers. Whatever the type of location of pod you're running, a pod always has three primary goals. The first goal is to triage. A pod is not a medical setting where disease is treated. Sick people should not come to a pod. If they do, they will either be turned away before entering the pod and told to see their doctor, or they will be transported to the hospital by ambulance if appropriate. The second is to medicate. So the bulk of our pod operations center around the process of to get pills or shots or vaccine to our residents. The last and third is to educate our residents. When they're arriving to our pods, they could be frightened and confused by the current situation, and they may not understand why they need to get medication. And it is our job as public health professionals to provide that education to them on why they need the meds, how to take the meds, and any additional instructions or information they may need. And our secondary goal, of course, is to care for behavioral health of the residents at the pod and to ensure we appropriately keep whatever records may be generated at the pod. Next slide, please. So pod versus clinic. So to meet our pod goals, we have to design pods to work a bit differently than a normal healthcare setting. Normal clinical operations strive to meet the highest standards in terms of both public care and public information. They record basic vital signs, take measurements, and get a medical history of each patient and conduct thorough exams. And of course, they document all of this through excellent record keeping. And mass dispensing, however, is not business as usual. It is the crudest and most basic terms of our mission to process people to either get them pills or to give them vaccines. And it's to do it as quickly as possible. And sometimes being MRC and working in a pod, you've heard probably the emergency planners or MRC coordinators talk about throughput, what's the time of people getting through. That is something we're focusing on to get as many people through as possible. So now let's look at some different models of pods, as Lean has already showed. Next slide, Megan. As Lena has already showed and talked about earlier, she talked about non-medical and medical pods. They're closed pods, but non-medical and medical pods. Non-medical model pods are used when the disease is effectively treated with oral antibiotics. In this model, we are handing out pills. And based on a medical license waiver from the State Health Commissioner, anyone can dispense. You do not need a medical license to dispense medication in this model. Also, this model works off a head of household policy, meaning one person can pick up for many. Then we have medical pods, which is, of course, different. Medical pods are used when injections are required. In this model, there is no license waiver, so it requires that medical professionals perform the act of medication dispensing. Also, because it requires an injection, each person must be there in person, so one person cannot pick up a bunch of vaccine and take those home. Our initial response will include non-medical pod model, but right now, considering our time and what we're going through COVID response, we'll focus on the vaccine model. Next slide, please. So with the non-medical pod, or even the vaccine, or the non-medical pod, and also the medical pod, we don't need any ID for when people come to our pod sites. And sometimes we have to remind people that IDs are not required to come, especially for a vaccine, the medical pod. A non-medical pod, when someone operates as head of household, they can actually come and pick up for their family. So pods work off of minimum information requirements, like I said earlier, especially the non-medical pod. The staff are not to check photo IDs to pick up medication. All we need is the full name and allergy status of doxycycline and ciprofloxacin. Also with the vaccines, such as the medical pod, when you're doing flu clinics, they fill out the form and they check whether they have allergies to, they have any egg allergies. Media shouldn't have access to the pod. You should run that through your PIO. Media are allowed to enter the pod like anyone else, but they have no additional access to staff and facilities. They cannot hold up the line to interview staff or residents, and they cannot veer in any way from the main flow of the line. Of course, if you're working a flu pod and you witness that, please let somebody know. Next slide. So the health department, and this is Alexandria Health Department structure, may not work the same way everywhere else. The health department is identified as the coordinating agency, in other words, the lead agency for any public health emergency. That means that we lead the local response, and the cooperating agencies or supporting agencies follow up our plan. Obviously, for an emergency of this magnitude, the city's Emergency Operations Center activates. That facility serves as a physical location in which cooperating agency representatives work to support the needs of our dispensing operations. A joint information system activates to ensure accurate, coordinated public message to get out through traditional and social media, and that the public messages are coordinated with public messaging from surrounding jurisdictions. Transportation is another major concern for an emergency and a response of this magnitude. Clients are allowed to drive to pods, so there will be street traffic and public transportation remains in service for residents without vehicles to get to pods. While we're getting ready to open doors to the public pods, first responders organizations, including health, police, and fire and rescue, are receiving their prophylaxis so that they are protected while they're out performing their emergency response roles. And finally, due to the severe nature of such an emergency, there would be local, state, and federal declarations of emergency to assist with state and federal support as well as additional funding. Next slide, please. So the public health role, the city will pretty much establish a unified command. The health director would assume the role as incident commander. When the health director, or for us, our deputy director, would establish a unified command with public health, police, and schools. We work with partners such as OEM to advise us on what the most reasonable unified command for something this large would be, and request support from the ESFA support agencies. And we will discuss our different roles as we get further through the slides. Some will be determined at the time of incident, and then just because you're not part of Unified Command doesn't mean you're not part of the response. Next slide. So here's a visual representation of the timeline we've been talking about for the first 24 hours. So this is definitely focused on a non-medical pod model, but we can still adapt it to the medical, a medical pod model. We have an incident that occurs. We learn about it some time later. A decision is made to dispense medication. And once that decision is made, we're off to the races, working to get all of those many activities we just talked through completed within 24 hours. So our pods are ready to open their doors to the public for 24 straight hours of dispensing. This is definitely based on a non-medical pod model that can be very well adapted to a medical pod model. Next slide, please. So here are some tips for being a supervisor. Now, I know here in our health district, a lot of our MRC volunteers have taken, and we've been so grateful that they have taken on the role as supervisor in our pods. And so just in case you are in that situation and you're working at a pod in your health district, just remember being a team leader, definitely be proactive. Find the problem before you start, or be able to work out that problem while you're with your team. Pay attention to your staff's needs, of course, be transparent, and don't be afraid to get your hands dirty, because at the end of the day, we're all a team and we're all here to work together to come out with the best solution. Next slide, please. So we've already talked about how the primary goals of the pod are to 1, triage, 2, medicate, and 3, educate. To our residents, this should appear as a fairly simple 3-step process. We know that there is much more to it, and there's many more functions occurring in a pod, but for most of our residents arriving at a pod, they should be greeted, dispensed to, and directed to the exit. During each of these steps, residents will be receiving education through a variety of formats, verbally from our staff, visually from the signage, and in written form with the disease and medication fact sheets provided during the dispensing steps. We estimate that our population will have a fairly simple A to B experience in the pod. For those who require additional assistance, either due to an access or functional needs, behavioral health assistance, or whatever the case may be, we build in guidance and support services to assist you in providing those additional needs. We'll look at those services in greater detail shortly. So we're going to briefly look over some of the roles that come in a pod. I'm not going to read everything to you, so I will allow you to read the slides. I saw somebody request slides, so hopefully those will be available to you afterwards. So the first, next slide. The first role is the pod command staff. The pod command staff would consist of the pod manager, and deputy pod manager, the safety officer, assistant safety officer, and most of the supervisors. So I will give you a moment to look over the pod command staff. So the pod manager and deputy pod manager direct all dispensing operations and are the ultimate on-site responsible party. They serve in a unified command when the ranking law enforcement officer and NHD employees on site, making decisions that impact the pod together. Next slide, please. The next other important role of our pods are the unit leaders and supervisors. I will give you a moment to read that as well. So during normal operations, unit leaders must document any injury or illness of staff within 24 hours of the event in the health department incident report database. During an incident, when the safety officer position and staff notify your HR department. Next slide, please. Right. So this is the greeter and screener. And you can read this while I talk. This is very self-explanatory. For the health department, for our pod, we use our greeter folks to not only greet the clients and welcome them to the pod and kind of explain everything to them, but we also, at the beginning of our pod, we take temperatures before we let them come into the facility. And actually during our drive-through pod, we actually took temperatures while they were in their car before they drove up to get vaccinated. Next slide, please. So form distribution and review unit, that's the next step in the pod. The form distribution is where they get their clipboards and their forms that they fill out, where they have those additional questions. Then they run into review unit after the form distribution team and they actually review the form to make sure it's completed to as best as it could be. Right, next slide, please. The dispensing unit now depends on whether it's a medical or non-medical pod. So we're going to talk about flu. Medical pod is when they're getting the vaccine. Non-medical pod is when they're getting the doxy or the Cipro. And it's one of our most busiest units this is one of our busiest units for our nurses and our MRC nurses. And we've actually, here in Alexandria, we've added a whole vaccinator assistant to that team to help out our medical staff. Next slide, please. Flow control, we cannot survive pods without our flow control unit. Sometimes you think you don't need too many people in flow control, but it is the lifeline of a pod. So you ever get on flow control in a pod, your role is more important than what you think it is. Next slide, please. So at this conclusion, this is the for pod demobilization. It is a bit of a gray area as far as what to expect because non-medical or medical model shutting down, or there may be some transitioning to continue pods. In general, as a pod operations end, the facility must either be returned to its pre-pod condition or transition to a follow-on pod to continue dispensing. The pod manager is responsible for securing SNS inventory or making sure that vaccine is back in place before we close up and ship out and go back to the health department. Next slide, please. So safety considerations, this is very important whenever you're working in a pod. You want to dial 911 in the event of a medical emergency. Provide CPR first, CPR or first aid if qualified. Inform your ICS supervisor and safety officer of an injury or safety issues you identify. Everyone has a role. Look for PPE exhaustion, signs and symptoms. With that being said, if you're wearing an N95, please pay attention to yourself, but also look at your partner that you're working with to make sure that they're okay as well. And if you see something, say something. Next slide, please. And it is the responsibility of each person to use the information they've been provided. So thank you very much. That is it.
Great. So Megan,
Thank you so much. My apologies, I was still on mute. So I'll go ahead and talk a little bit about the COVID-19 vaccination. And thank you so much, Adrenia, and thank you, Jasmine, for that great presentation. Just as a reminder, we're going to take some more questions at the end. So we do notice that there are some questions in the chat. And so if Lean is not able to answer those immediately in the chat, we will be pulling those to the end of our presentation tonight. So with that, I'm going to be talking a little bit about the COVID-19 vaccination. I want to preface this, though, to say that we are still limited in our full knowledge of what the vaccination would look like. I know that there's recently been some press releases regarding Pfizer. So, you know, there are some different things out in the media right now, but in terms of VDH and the MRC, we are still working to prepare for any and all vaccine candidates, as there are several in the United States right now that are in phase 3 trials. So this will be a very general, non-specific vaccine overview of some of the CDC's playbook. So as I mentioned, plans are underway right now at a federal and state level. VDH recently submitted their initial plan for vaccine disbursement to the CDC back for review in October. There is much speculation about which vaccine candidate will be utilized first. As I mentioned, the Pfizer candidate vaccine was discussed, you know, fairly at length this past week in the media. But we will know this essentially when most of you guys do. This will be announced fully once the science is ready and prepared. And we are not to that point yet in our current situation. To give an understanding just about the broad view of this, there are roughly about 150 different vaccines under developed and being studied throughout the world to fight against COVID-19. And 6 of those are in phase 3 trials for the FDA currently. And phase 3 trials, just in case you're not unaware, they cohort tens of thousands of people and follow them for a set amount of time to ensure that there are no physiological consequences to the trial participants and that the vaccine produces an immune response for the candidate. So given that we will likely have a number of different vaccines available in the coming months, it will be really important to know how to utilize a variety of different models and public distribution. So some considerations that I know that were brought up in the chat already are cold chain management, logistics, observation time period for those vaccinated, follow-up if there are multiple vaccines in a series, etc. So a lot of different aspects are going to come to play in this specific type of model to respond to COVID-19, because as Lean and Jasmine mentioned earlier, this one would be considered a medical pod. So what we do know is that the MRC will be a very important part of this dispensing process. We are already committed to getting ready for the vaccination and to be an integral part of that dispensing process. So the chart that you see before you is a chart that was produced and sent out by the CDC and is fairly publicly available and has been shared in different media sites. So nothing secret here, but did want to just bring this up for you to kind of have a good understanding of what the federal expectations are and also state expectations. And my apologies, this is as large as I can make it right now, but we will send these slides out and I'm going to be talking about some of those smaller printed areas. So my apologies, I couldn't make it any bigger on this particular screen. But just to kind of start out, this shows a different, a phase 1, 2, and 3 area for the distribution plan of the vaccine. Phase 1, as you can see on your left-hand side in that light blue, is primarily looking at the early stages, moving from the trial phase into the startup of vaccine distribution. So in this phase, as you can kind of see by that blue line that is circled in red on your screen, we're going to be moving from no vaccine available to the public to, mass vaccination eventually in phases 2 and 3. But that phase 1 is probably the most important part, because whenever you start something, I feel like that's probably the most important time period to anything of this type of nature. So as you can see, we're going to move from having a limited supply for early distribution, which will be used to vaccinate priority groups. And the vaccine is going to be administered primarily in closed pod settings. So in phase 1A, paid and unpaid healthcare workers and those working in healthcare settings with the highest potential for infection would be the first to be vaccinated under this strategic plan. Phase 1B, which is listed in that lower portion, and I apologize that it's so small, that will be listed as other non-medical essential workers, people at higher risk for severe COVID-19 illness, and also to include those ages 65 and older. There's a bit more of a breakdown even further in terms of who can get this vaccination in that phase 1B portion, but your big takeaway today should really be that phase 1A is going to be those healthcare workers with direct patient care who have the highest potential for infection, and phase 1B should be those next level folks that may have a high risk of infection and high risk of severe COVID illness in the next highest group. And as more vaccine is going to be manufactured and more different types of vaccine are available, this will continue to scale up. And so you will see more vaccine in the community. And therefore, the types of pods will likely shift to include broader groups as well. So as we shift to more open pod settings, as well as commercial and healthcare offices, that will happen once more vaccine is readily available. And as you can see into the phase 2 and phase 3 portions, phase 1 will continually get priority, but other critical populations and the general population will begin to start being vaccinated into that phase 2 portion. Phase 3 is once we get into kind of a more controlled and continued vaccination. So if the science bears out that this needs to be had every, annually, every 5 years, et cetera, or just for people to have it for the first time, that will be in phase 3. So, and those are some of the things that, frankly, right now we do not fully know. So we are still working to be aware of those things, but in the broad scheme of things, it's important for us to go ahead and plan and to be ready for as much as we can be. And eventually, eventually we'll be shifting to that routine vaccine strategy. Now, I know that I've covered a lot here, so I'm happy to take some questions at the end about this, and I know that Lean is helping to answer some of those in the chat. Thank you so much, Lean. But for now, we are going to go ahead and shift over from the discussion about the vaccine itself to a little bit more routine pod experience from some of our volunteers. So I'm going to go ahead and introduce, and I'm going to stop talking and introduce Judy Mehring and Jeff Schulin, and hear a little bit about their experience working as both medical volunteers and support volunteers for Prince William County in pod settings. So Judy, if you want to go ahead and start.
Sure. Can everybody hear me?
Yes, ma'am.
Cool. All right. So as you see, I've been a volunteer for quite a few years. So I've been involved in multiple exercises. So there's lots of different experiences behind me. So they gave me a couple of questions that I'm going to give you. So they said, what should volunteers do to be ready? And the first thing is, I think, remember, you got to stay healthy. So remember to exercise, eat healthy, and get your sleep, because you got to be ready to go. Attend the trainings, pay attention, take notes, review those trainings. I did all the online vaccination courses, and I have printout sheets that I reviewed before I did those vaccinations to refresh my memory, because I'm not working every day as a nurse. So I need to refresh my memory. Know your limitations. If you can't do it or you think you can't do it, don't do it. If you can't work a 12-hour shift, don't sign up for a 12-hour shift, okay? I think that I have to do personally is practice. I am not good at handling irate clients in my face without a practice answer in my head. I just don't think fast enough. So I have to practice ahead of time. If this happens, then what do I do? So I do a lot of what if scenarios in my head prior to a pod. Ask for help. This happened on the last vaccine clinic I did. They said, here, you get to do the toddler. I've not injected a toddler in 20 years. I was like, okay, I can do this. And I had another volunteer with me who does it a lot, and she made sure I did it correctly. So then I'm comfortable, and now I can go on and vaccinate toddlers. The other thing is this happens to me. We got a new car. I'm like, where's my badge? I don't know where my badge is. So make sure you know where your badge is, where your t-shirt is, and be prepared. The other one is if they tell you you're going, dress appropriately. I still get lots of hot flashes, so I have to dress in layers. I forgot my sunscreen at one. Guess who came home sunburned? So dress appropriately, pack what you need, pack your snacks, pack your water. They'll supply those for you. But again, if you have your own, then you know you're set to go. So just be ready. So what roles have I done? I've done everything to being one of the participants, meaning I'm a community member going through the lines. I've been timers. I've vaccinated. I've monitored the people post-vaccination, because we do have to monitor them post-vaccination for results. I've been a fit tester. I've dispensed medications. And I've been a greeter and a little bit of flow control. So I think pretty much I've done all the little jobs that are actually needed to make a pod run. What to expect? Be patient at a pod. Follow your instructions. They always give us just-in-time training to make sure that we know what we're doing. And if you don't, ask those questions. The other thing at a response to a pod is if you notice there's an issue, speak up. And if you have a solution, speak up again. At one of the vaccination clinics, we didn't know when to release them for their 15 minutes because we didn't know when they got injected. And that was really hard to try to judge when they came out of line and when we should let them go. And so the next time we had times on their cars that said, this is the time they got injected. This is the time you know when to go. So those things are helpful. So speak up if you see there's an issue. Lessons learned, smile, be patient. And just, it's really be patient and be prepared, because it will go. You can do your job. And if you have a question, there's somebody who can answer it for you. Thank you.
Thank you so much, Judy. I really appreciate it. So just to go back to this page just a little bit. So now we'll get some questions from Jeff. So Jeff, if you want to go ahead and introduce yourself.
Okay, can you hear me?
I sure can. Thank you.
Great. All right, my name's Jeff Schulin, and I'm a retired paramedic. And I also spent 26 years as a volunteer in the Prince William County Fire and Rescue Service as a firefighter as well. I've joined MCR back in the spring. Since I'm retired, I have a lot of free time, and I thought maybe I could find something I could do to be useful. And they kind of put me to work. I've done a lot of COVID testing sites, and then a few, we did the tetanus shots, and then the flu shots as well. So my experience is not medical. I'm no longer a medical person. They don't let me near a sharp needle. And so that's probably safer for everybody. But a couple of things that I picked up from doing these is that they work a lot better than I would have ever thought. You bring a bunch of people that basically never worked together, doing the online training and then the just-in-time training. And I'm just surprised how well people work together. That's been really impressive. Not to say that we couldn't find things to improve. And Judy hit really all the high points of what I was going to say. But my last role was as a safety officer. And we did it in a parking lot, and we had a really good plan because we had like a satellite view of the parking lot and where the cones are going to be. And so the flow control coordinator knew exactly what they're going to do. And then we got there that morning and someone had parked a car in the middle of that parking lot, been there for several days. So that completely threw that plan out. So they had to change the cone pattern. We wound up having people standing around waiting to get into the area, standing in a parking lot that people were pulling in and pulling out, going to a grocery store. So we had to basically move everything around so people weren't being endangered by people backing up in cars. So it turns out, safety officer, I did a lot of things that I didn't really plan on. One thing is, everybody's a safety officer. When I gave my safety briefing before we started that morning, I said, everybody's a safety officer. You see something, say something. That's really true. But as a safety officer, you need to be kind of detached so that you're kind of walking around getting the big picture. And you're touching base with the incident commander and the medical personnel, the logistics personnel, and the coordinator for the flow, because they will probably pick up a problem and say, hey, here's a problem over here. What do you think we can do? And you try to figure out what works by putting your heads together. In this case, I think I identified 4 things that we had problems. They may be not all safety related, but they kind of intermix. One was signage. We had a sign on the sidewalk that said, that we're doing the flu shots. But the first time we found out that we had a language barrier. Not only do we have some people that don't speak English, they don't read English. So you put signs up, but they're not in Spanish, or then that's kind of lost them. I had this one lady that went right through all the cones, walked in the back way, and I had to kind of like route her, no, go over here. Second part of that is that you have to identify who your bilingual people are and use them to your best advantage. If you have a bilingual person, them directing traffic in a corner doesn't make sense. Put them where they can help people fill out their forms or answer questions. So again, use your resources wisely. You need a bailout plan, and a bailout plan would be the flow you had set up isn't working for some reason. In our case, because of a car sat in the middle of the parking lot, that we just had to modify things on the go and see if it worked. And okay, that seems to be better, but let's move these cones over and route them the other way. It's one of those things where you can plan all you want, but until you get on the site, you don't know. Some of the safety issues we had was the wind. We had cones that were constantly blowing over. We had the yellow tape between cones to delineate areas. Well, the wind picks up that tape and knocks a whole row of cones over. We had 3 shelters, shade shelters over the clinical areas. They started becoming kites. We had nurses holding down legs of those shelters, keep them from flying into the road. So we had to take them down. And I think I talked about the traffic issues. So again, you plan the best you can, but you have to adapt on the move. In my role as a safety officer, I wound up doing a lot of different things, but the big thing is that everyone's a safety officer. Everyone's responsible. Some of the things Judy said about looking out for PPE exhaustion, we didn't have that problem that day because it was fairly cool. But you can tell people bring sunscreen, bring a hat, sunglasses, etc., and still some people, they're too dense to listen, wind up burning the top of their head because they forgot there's no hair up there anymore. So lessons learned, you go on, next time you do a little bit better. Last thing I'd say is just kind of reiterate is I was extremely impressed at how well this thing ran. Certainly, yeah, we could get better at it, but I think the more we practice this, the better we're going to be able to adapt and do a better job for the people who are serving. I think that's about it for me. I know I didn't answer the questions exactly, but Judy answered all the good ones.
Oh, no, you guys did great. Thank you so much. And I think that this really does help give a lot of perspective to other MRC volunteers. And I'm seeing that reflected in the chat box as well. So thank you guys so much for that. If there are any questions for Judy or Jeff specifically, feel free to put those in the chat. We're going to move on just in general to questions overall, but we'll be sure to ask Judy and Jeff any questions that you may have in terms of experience as well. So with that being said, I'm just going to move into a couple of the questions, and we will try and answer those for whoever is available. This first question is probably best served for Jasmine or Lean. And this is, may NPs or nurse practitioners run a medical pod?
Could you repeat the question, Megan?
Yeah.
Yes, and it's very difficult to hear you.
Yeah, I got it in my face. We're good.
Okay. May nurse practitioners run a medical pod?
So I can go ahead and answer it, and then Jasmine maybe can add to it. This is Lean. So during emergencies, normally the governor will relax requirement for vaccines. So it's actually a lot of people will be able to give vaccine as long as they get the training to be vaccinator. So LPN, RN, all different, even non-medical, as long as they get trained and be ready, they can go ahead and give vaccines. Because as I said, laws will be relaxed by the governor.
Great. And then given the possible requirement for handling vaccines requiring extremely low temperatures, logistics training for handling under those circumstances, training for medical personnel as well. I think that this question is asking specifically if we will have specific training for the logistics piece, especially for the Pfizer vaccination, which I know publicly was made aware to everyone that that's an ultra cold vaccine storage. We will definitely be giving that additional training, and it is already actually being planned out for what types of training are being needed for that particular logistics for that cold storage. But those will come with any final plans as we are aware of which specific vaccine will be made available. And that mainly has to do with the fact that each individual vaccine has its own cold storage requirements. So the next question is, are there any pod trainings that you can recommend for lay volunteers or the lay public? Jasmine or Lane, if you guys want to answer one of those.
So I will say with the same.
Jasmine, we're having a hard time hearing you.
Oh. Can you hear me now? Can you hear me better?
Very, very lightly.
I don't know why. Hold on 1 second. I know another way to fix it. Okay. Can you hear me better now?
Yes, much. Thank you.
Okay. So with the pod training for the layperson, it would normally be your training with your local health department, and especially with your MRC team that provides the training. I know here in Alexandria, our MRC coordinator, Lutai, normally sets up trainings with our MRC volunteers to have a pod training. We do pod exercises regularly. We just completed 2 flu exercises, and we just actually had one today here in-house, which was another exercise of pod, just a different style, more of a closed pod type. So I would definitely pay attention to your trainings that's coming through, not only from our state MRC team, but also through your local health department.
And I just want to add to the exercise part, to the training part. When MRC, when you see this alert that is say vaccine pod, this is actually our way of exercising for the big pods. So normally when you see those vaccine one, these are the one that actually we're training and we exercising those plans that we have for our pods. So when you see it, if you're interested to go in, that's when you actually can exercise all the things that we have said, that you can see it, because it's not a high pressure. It's just we're training, and we're training our people, and we're training the volunteers, and we kind of going through the plan as we go in a more calm environment. So if you like to participate in those, just look into those alerts when you see it.
Great. And then another question regarding pods is, does pod registration process without ID provide enough data for analysis or projection of subsequent need? So second dose, for example, of yet to vaccinate population.
Oh, I can answer, maybe Jasmine can add to it too. So yes, we don't ask for IDs, but there is a form where we call it the head of household form. That form will allow us to collect enough information, the data that we need to have, if there is any follow-up, if the adverse reaction, if they need to come back for another vaccine or another pill. That form will help us to reach out to them. It has the address, their date of birth, and if they have any medical issues. So there is with that form, we can collect the data that we need. I don't know if Jasmine wants to add something.
Yes, so the system that we may be using for the COVID vaccine will allow us to be able to send out a date to the folks who get vaccinated for a reminder for that second dose. But other than what Lean has said is completely correct. But there is a mechanism in place to make sure people do get their second vaccine.
Great, thank you guys so much. And so the next question is, what kind of PPE is available for MRC volunteers who fail the N95 fit test? It depends on what you are doing at any point of either vaccination, or if you were working with directly known COVID patients. So your PPE really requirements are based on that. I would say if you're not working with COVID positive patients, typically you're using a surgical mask, gloves, and then a face shield. If you're working with positive patients, then that failure of the N95 fit test would come into play, and you would need to check with your coordinator before any kind of deployment, because you would not necessarily be able to wear that N95 mask for the duration of your volunteering if working with a COVID positive population. And when I say that, we're looking at different deployments such as testing, et cetera, where you may be face-to-face with someone who is actively infected with COVID. I know that I believe Lean gave the link to the CDC chart. I will try and get that for you again, but I believe it is in the chat box. So hopefully you were able to see that. And then also another question that we had, and they're kind of coming in quick, so I'm trying to catch as many as I can. How will we verify whether or not people fall into phase 1A or B, and therefore determine who will get the vaccines first? This will be handled by the state and local health departments. So as part of the plan, they are going through and understanding who would fall into each category based on job roles. As we mentioned earlier, the healthcare patient-facing providers, which I should have started this out with earlier on as I was discussing. But if you are an MRC member and you are working at a vaccination pod, you would be considered patient-facing and would be in that healthcare worker 1A category. So that being said, it is not necessarily based on the honor system. We have a lot of health data that we can use to see whether or not someone is in each category. And we also have things like employer data, et cetera, that we can quickly tell some of those things. And that's already been, I know that that has been factored into the plan so far. I know that there was a question about, is there a copy of the Virginia plan? I know that there is a copy. I don't know if it has been made public yet, just because it is still underway, since we don't necessarily know the full scope of the vaccine specifics. So we will definitely let you know about that plan more as it is made public.
I put a link for the draft. It's just a link from the CDC, what Virginia's plan. Each state, they have a link there for each state, what they're planning to do. The plan, sometimes we don't publish it publicly. It's just because it has a lot of data and a lot of information that we don't think it's publicly should be seen. But overall response plan, you can see it. I sent the link a little bit early. I can resend it again here in the chat.
Perfect. Thank you so much, Lean. And just to reiterate, though, that plan is a draft. And so we'll be, of course, updating it with more specific information detailed to the actual vaccine. As of right now, each vaccine that we're aware of that's in phase 3 trials has a different piece of that plan, but it will be fully enforced once we know more of the specifics. And of course, you know, those will be bared out by the science again. And then I believe there's one more question about personal identifiers and whether or not person identifiers will be required for vaccination to verify identity and to track their current vaccination status.
So I think we kind of answered it in a way.
Yeah, I believe
as I said, yeah, that form that we make sure the volunteers, the public or anybody come through the pod fill out, that help us to get back to them.
Great. And there's been several questions that have come into the chat while I've been reading off the ones that we had gathered. There's a question about sharps containers and trash cans and Band-Aids, et cetera. Those have been factored into the plan as well. Some parts of what we're utilizing for the vaccine are going to be provided by the federal government. Other parts will be provided by state government or localities, depending on what those needs are. So just to answer that question, hopefully that answered your question. And then also there's a question about ultra cold vaccines are warmed up before being administered. Yes, that's a fair question. So the vaccines that we're being made aware of at this time would probably involve diluent, which would allow it to be transferred from an ultra cold storage and then given to a human, of course, so that it's safe to give. And hopefully that answered your question. And then refrigerators for ultra low temperature vaccines are very expensive, and will pharmacies be compensated for those? Those right now, I understand that there are going to be more of those refrigerators and freezers, et cetera. They're also looking at different ways and mechanisms to bring vaccine to areas where maybe a refrigerator or a freezer is not necessarily available with dry ice, et cetera. So those plans and details are being factored in as well. There's a question about whether or not someone can vaccinate with their foreign nursing license. I can speak to that a bit. So at this time, those that can vaccinate must have an active Virginia state health professions license. And so if you had a foreign nursing license and you were able to also get a Virginia license number, then you would be able to vaccinate. If you do not have a Virginia license, then you would need to check with your individual medical unit for MRC, but likely not at this time. That may, some of that may change into the future though.
Hey Megan, it's Jennifer. Can I hop in and answer that question?
Certainly.
Hi, everyone. I've been a little talkative in the chat. I'm Jennifer Freeland, State Volunteer Coordinator. I see many people's names in the chat box that I know, so thanks for joining us tonight. We are making some modifications and actually really looking to expand who can vaccinate. We call it the traditional vaccinator versus the non-traditional vaccinator. So we're currently going with the traditional vaccinator, but we will be looking at how do we push the envelope of expanding our vaccination workforce. In Virginia, we are a part of the nursing compact state, which if you're a nurse, you probably are aware of this. The surrounding states, Tennessee, I can't remember how many there are. I'm sure Melissa Early can write it in the chat box. Many states across the nation are in a nursing compact. So for example, if you have a nursing license in North Carolina, then you can practice in Virginia. Unfortunately, that is not the case for DC. They are not a part of the compact state. So that is available to nurses. We don't have the same for physicians and other healthcare provider types. We have discussed the foreign license. That becomes difficult to verify competency or education when the license is out of the country. It's easier when the license is from another state. EMS providers can vaccinate when they are affiliated with their EMS council and they've been signed off by their Office of Medical Director, OMD. We are also looking at allowing now volunteer nurses, registered restricted volunteer nurses can vaccinate. I have gotten that approval, and we're waiting to look at our physicians that have volunteer licenses as well to see if we can allow them to vaccinate. There has been discussions about veterinarians and dentists. I think that's still on the to be determined list. But right now we're going with what we have. Each of your coordinators do have our guidance for who can vaccinate, and I don't know, we are going to put up a web page specifically for vaccinators, so we can make sure the coordinators can provide that out to everyone. But I think that hopefully provides some clarification. You know, ideal versus realistic. We're looking at our traditional, but we are looking at ours non-traditional. We will be relying heavily upon Medical Reserve Corps volunteers and also our student nurses. We have some dental students and actually working very closely with VCU Pharmacy School and likely Hampton University as well, so that those students can also assist us in vaccination efforts.
Very much, and thank you so much, Jennifer, for adding that. There's several questions regarding whether or not the pod locations have already been determined. Those pod locations will be known a little bit more as we kind of move forward. Again, we will start with certain healthcare groups first, likely, and then from there they will get broader and broader. So it's hard to say specifically where pod locations will be at this point, but as we know that information, we'll be sure to share it with you guys as well. And you'll definitely start seeing alerts once we are actively vaccinating.
I just want to add to that, Megan, that all jurisdictions, they have their pod already picked and signed, so they know. It's just we don't provide those information to the public until we open that pod.
Yeah,
but
exactly.
As I said earlier, mostly high school, gymnasium. So if you have a high school next to you, it's probably that's going to be where the pod is. Universities, big gyms. So we kind of already have an idea of each jurisdiction where they're going to have their pods are. And we have that in the system. So when we send the vaccines, we send it straight to the pod.
And the reason I hesitate to say that as well is because even the nature of the situation can bear out which types of pods are where too. As we've seen with COVID, just in general, we've had a lot of testing sites that were drive through and drive up. So that's something to consider too, as how this may look in different parts of the state and different parts of the Commonwealth specifically. So Northern Virginia had a little bit less of probably the drive through model than maybe say Southwest or Central or some of the other parts of the state. But as Lean said, yes, we know where those will be. It'll just be a bit more stated once we're ready to make that publicly available. There's a questions about whether or not we can see forms ahead of time. I'm guessing that would be related to forms that you mentioned, Lean, earlier on in our discussion for identification.
Yeah, correct. We have a state form, and some localities, they kind of have their own form that they fix it a little bit. So I think it's available publicly. So let me see if I can find it somewhere.
And specifically, they were wanting to know about other languages, which brings us to something that I know you're working on to specifically address different languages that are of need in different parts of the Commonwealth as well.
I think the form we have in Spanish and English, but then, as you said, we're working on training those volunteers to be interpreters as well. So we're going to have that program. But right now, I think the forms is only in English and Spanish.
Right. And then another question is, when will public education campaign begin to educate the public about the vaccine to convince them to come and get the vaccine? So that's already being planned out and underway in some senses. But as we specifically have those individual vaccines, we'll be able to publicly communicate that information a bit more readily. So that should be soon to come if I were to estimate. And then let's see, got a couple more questions. I'm just going to skip down. If anybody has anything to add, feel free. Do COVID positive patients still get the vaccine at that time? That's a great question, Lori. And I think that Lean may have addressed this early on. It may have been Lean, may have been Jasmine, about whether or not someone who is sick with COVID could come and get a vaccine. So I'm going to let them answer that. So Lean or Jasmine, whoever wants to take that question.
Hi, this is Jasmine. So yes, if somebody is COVID positive, we would actually do the screening at the beginning of the pod and ask them all the screening questions. After we ask them if they pretty much say they're COVID positive, we would actually send them away and tell them to go back home and quarantine. So no, we would not let them in to get a vaccine, but they would be able to come the next event that we would be having after they're done with their quarantine.
Great, thank you. And then there was a question about whether or not the COVID vaccine would be entered into VIS, the vaccine information system, and whether or not having had that, your information would be entered, and that would be entered into VIS so that we have a record of who had gotten their first vaccine, and then once you came potentially for your second vaccine, that second vaccine would also go. And that goes for pretty much any vaccine that you're given in clinics and pods, et cetera, throughout the state. And then this question I'll bring up to you, Lean and Jasmine. What is the plan to alter our current pod practice to accommodate the need for every individual needing to be monitored post-vaccine for reactions?
So I've seen in some plans that they have a designated area where people, after they're given their vaccine, they can sit there for as long as they let them know. I mean, probably 15, 20 minutes, I'm not really sure. But I've seen some plans, they have that already, locality plans. And I've seen it in person too, in some pods, that they have a separated designated area for people to sit and wait to see any first reaction. But then after that, after they leave, go home, we give them information. We'll give them kind of like vaccine information and where to call if they feel anything or if anything happened to them after they get home.
Great, thank you. And then Richard asked, can personal information be provided and have the vaccination put into VIS. I think we've answered that. So once you receive the vaccination, you could be, your vaccination status would be put into VIS, into the VIS system, excuse me. And then the next question is, any idea how long it takes to thaw the ultra cold vaccine prior to the administration, or will that be in the reconstitution instructions from the MFR? That will likely be in the MFR reconstitution instructions. So we have a kind of rough understanding of that, but very specific how-to instructions. Those will likely come with when we know exactly which vaccine we are going to be giving at each individual pod. So we will know that, of course, ahead of time as the vaccines are made available, but especially as we are vaccinating with more and more different types of vaccines, which is kind of the assumption, that will be more and more important as we move forward. And then let's see, I think I've gotten most of the questions, but still kind of moving down. Do we have a rough timeline of when the pod will take place? That question is a hard one to answer because we're going to have a lot of different types of pods. So Lean or Jasmine, if you want to give any specifics upon that.
So normally the federal government will give us about 12 hours to get ready. So once we receive the go that these vaccines is going to come, we're probably, because they need to be administered within 48 hours. It depends on the COVID-19 they might give us a little bit of flexible time to set up our pods, but we have plans to be ready within hours when they say active and go. Jasmine can add maybe more, since locality might have a good answer for that.
So I will add to what Lean said. So I will just say we're planning, and no, we do not have a specific time and know when pods will be open for COVID. But I will say that I'm more than sure that health districts are underway with heavy planning and being prepared for when that time does come.
That sounds great. And then I know that there was some questions about whether or not you could work or that whether or not you could volunteer if you lived in DC. I believe Jennifer answered those, but you could certainly volunteer. But we do suggest trying to volunteer wherever you're kind of close to. So if you work in Virginia and it makes sense for you to volunteer, that's great. And we would be happy to welcome you. And same way if you live here, just meaning that we want to make sure that you're able to participate as easily as possible. And then another question I'm seeing is, what is the interval between the initial and second dose? This question is a little bit different for each individual vaccination, but for most of the 2-dose vaccinations, it's between 21 and 28 days. And I believe, and on. So for example, if you got it at day 30, that would still be acceptable, but you could not go any earlier than that 21 to 28 day range, depending on the individual vaccination. But again, some of these questions are specific to that individual vaccine. And then also there's a question about, can I receive a Pfizer vaccine and then receive your second dose as Moderna? That question was asked in a separate meeting that I was in today. And the answer was that if you get the first vaccine as a Pfizer vaccine, just because they are different types and styles of vaccines, you would need to follow up with the same vaccination for your second round or second dose. And I believe that gets most of the questions. So I will say that we're getting close to the top of the hour and we want to respect your time, especially on this Thursday evening. I believe we've gotten most, if not all of the questions, but for if some reason you do have any questions, please do let us know. You're welcome to contact us at the email on the screen, the vamrc@vdh.virginia.gov. And then I will go ahead and turn it over to Adrenia to kind of close us out for this evening.
Add something quick. Somebody asked about disaster mental health. Adrena, do we have that training available in our training, or because I know it's online everywhere, they can just type up disaster mental health and it's a quick training that people can get it. It will make them prepare, ready for kind of disaster. Or Adrena, if you have anything that you can kind of recommend to folks, that'll be great. Thank you. Thank you everyone for coming today. Oh, psychological first aid. Yes. Thank you, Jennifer. That's the one, psychological first aid. Thank you.
And if you contact me, I can send you to the website if you don't have the MRC training calendar that provides the training links. So we want to thank everyone for attending tonight. Thank you for your service as a volunteer. We want to thank all of our facilitators for joining us. I have put in the chat box the link that you need to complete to say that you attended tonight. And the secret phrase is Pod Rocks. And we're so glad that you are participating. And Jennifer has also put the training link to the web page in the chat box, so you can see that link, that web page for virtual trainings that we have that MRC volunteers can offer or take, I should say. So again, thank you all. If you have any questions, feel free to give me an email, a shout out. Thank you all again. Have a great night.